This phenomenon is being confirmed also by a pilot randomized control trial from Great Ormond Street Hospital in London. However, the long-term consequence of this finding remains unclear. The aims of the present study were to investigate whether thoracoscopic repair of esophageal atresia or congenital diaphragmatic hernia was associated with acidosis and hypercapnia, also at our institution, and to analyze the effect of acidosis on early postoperative complications. For this study, we included all neonates born with esophageal atresia or CDH who underwent thoracoscopic repair sick kids between 2004 and 2014, and we included all patients with intraoperative arterial blood gas values recorded and available for analysis. We initially made a comparison between pre- and intraoperative arterial gases, then looked into the effect of intraoperative pH on the conversion rate to open surgery, length of postoperative ventilation, anastomotic stricture in the esophageal atresia group, and recurrence rate for CDH. For both conditions, thoracoscopy was carried out with both lungs ventilated, the patient in a semi-prone position and with low insufflation pressures. During the study period, there were 148 patients with esophageal atresia undergoing repair at sick kids. Of these, 21 were done thoracoscopically, and we had intraoperative arterial gas values available in 13 of them. During the same period of time, 155 CDH patients underwent repair as sick kids. 33 was done thoracoscopically, and we had available arterial gases in 22 of them. For both groups, the average birth weight was above 3 kilos, and patients were born at term. When we looked at the intraoperative arterial pH, we noticed a significant drop both in the esophageal atresia and in the CDH group, and a concomitant rise in the intraoperative arterial partial pressure of carbon dioxide, both in esophageal atresia and in the CDH group. We looked then at the intraoperative acidosis level, and we found that 77% of the esophageal atresia patients and 59% of the CDH patients had developed severe acidosis, which was defined as a pH of less than 7.25. Interestingly, only 15 patients in the esophageal atresia group and 18 of the CDH group had maintained normal gas values. Not surprisingly, the operation length significantly correlated with the degree of acidosis. But when we looked at the conversion rate to open surgery, only one patient in the CDH group underwent a conversion from thoracoscopy to open surgery because of acidosis. The median postoperative ventilation time was 4 days for esophageal atresia patients and 5 for CDH, and this did not significantly correlate with the degree of acidosis. The overall stricture rate for esophageal atresia was 54%, and there were no significant differences between the three groups. The overall recurrence rate for CDH was 32%. 23% of the patients with severe acidosis developed a recurrence, 40% in the mild acidosis group, and 50% in the patients with normal pH values. So in conclusion, Mr. Chairman, ladies and gentlemen, patients undergoing thoracoscopic esophageal atresia or CDH repair do develop intraoperative acidosis also at our institution. However, this phenomenon does not seem to correlate with postoperative complications. Further studies are needed to evaluate whether acidosis during thoracoscopy is associated with long-term neurological sequelae. Thank you for your attention.
Thank you very much.
No time.
Ladies and gentlemen, I'm sorry, for the purpose of time, could you please take up your questions with the presenters after the session? We are running short of time. And I know a lot of you would like to get ready properly before this evening's entertainment, so we'll give you an opportunity to do that. Thank you.
We're going to move on with the next